on our course book, Critical Thinking in Clinical Research. So everyone, in this video we are going to talk about blinding. And what is blinding? Well, blinding is concealing the allocation of each group to control or to treatment after the randomization. So let's go here. Well, we have our study population. Then we are going to divide this population into our control group and treatment group, for example. This process of allocating this subject is called randomization. And the randomization can also be blinded, but we don't call it blinding. We call it allocation concealment. And after the randomization, in order for the subjects do not know which group are they, in which group they are, we call it blinding. We need blinding. So blinding is basically allocation concealment after randomization. Alright guys, do not forget, after, alright? Well, who can be blinded after all in a clinical trial? Well, everyone can be blinded.
Is it feasible? Then is another question that you gotta answer.
Well, so basically, we can blind subjects, clinicians, we can also blind outcome assessors, endpoint committee, data handlers, data analyst, and manuscript writer. So guys, as we already know who we can blind, let's go now for the types of blinding a clinical trial can have. So first we have an open label trial. What is it? Well, it is a trial that is not blinded at all. Subjects, clinicians, outcome assessors, data managers, everyone knows the subject allocation, right? It is usually
used in, for example, in trials that the placebo or the intervention are too different, so you cannot hide or you cannot do a sham surgery, for example, or for example in trials that involve devices, it is hard to do a placebo form, so those are open label trials.
Then we can have trials with blinded endpoints. In this kind of trials, subjects and clinicians are open label, but outcome assessors are blinded. So those people evaluate the outcomes, the endpoints, so they are blinded. They don't know which subject was in each group, right? They don't know the allocation. It prevents certain biases at interpreting data, right? Well, we have then single blind studies. Well, single blind studies is usually interpreted as subjects being blinded, but that is not actually the definition of single blinded. Single blinded is among all these groups, one is blinded. Usually it is subject, but that is not the definition, right? So we gotta pay attention to that. Well, double blind, same thing. We have all these individuals here, two groups are blinded. Usually the groups that are subjects and clinicians, but that is the general situation, not 100% of them. And triple blinded, same thing again. All these groups, three are blinded, usually subjects, clinicians, and we usually join clinicians and outcomes assessors and data analysts or data managers, right? We can also have a quadruple blind study that would usually involve these three subjects here and data managers, alright? Well guys, but what are the consequences of unblinding? Well, unblinding, as you can imagine, can increase the biases of our clinical trial. But what kinds of biases specifically? Well, first, performance biases. This kind of bias is when a clinician provides care in an unequal way. Well, he knows which patient is in control and treatment, and conscious or unconsciously, the clinician can alter or interfere clinically, can provide care in a different way. Well, detection and observer bias is the, how can I say it? Well, we just see what we want to see. So if we know that, for example, a patient is in a treatment group, well, we can pay more attention to adverse effects of, for example, the drug, or for the benefits that the drug is supposed to cause. So we just see what we want to see. So that is a partiality in the evaluation of the patient, of the symptoms, right? Well, attrition biases. If a patient knows that he or she is in the control group, he or she is taking placebo, well, there is a bigger chance of this person dropping out of the clinical trial. So these dropouts that occur differently in groups, in control and treatment groups, can at the end of the clinical trial cause that these groups don't have the same characteristics anymore. So this difference, this imbalance of characteristics between groups is called attrition bias. We can have loss of placebo effect, which is a positive effect, let's say so, of placebo. Then guys, a response or self-report bias. What is it? Well, if I know, for example, that I'm on treatment group, on the intervention on the new drug, well, I can emphasize in a report, in a self-report, the benefits of the new drug, for example, or the contrary, I can emphasize the adverse effects. Maybe people that know they are in control group, they can increase, for example, the pain they are feeling because they know they are on placebo. So the self-report can be extremely altered from if people were blinded. Non-compliance. Well, the patient is not compliant. The patient does not understand the protocol, and he or she can break the protocol and then alter the results. Co-intervention basically is a non-compliant behavior. Patient is not compliant, and what is it? Well, I know I am in placebo group and I'm feeling pain, for example, so I take another drug. I take a drug that is not in the protocol, so I can relieve my pain. Well, the overall results of unblinding is the overestimation of the treatment or the new drug's effect by actually around 17%. That is actually a lot of things. So what is the lesson that we take from blinding? Blind as many people as you can, in order to avoid all these biases and in order to avoid this overestimation of data results, right? Finally, guys, how can we accomplish blinding? Well, when we are talking about pharmacological treatments, when we are talking about drugs, we can develop a placebo. That is also known by you, right? So the placebo, what is a placebo? It is a pharmacological, it is actually a substance that is not pharmacologically active. It does not have any effect, although there are some placebos that are called active placebo, that they intend to mimic the adverse effects of the drug, the interventional, the active one. But usually placebos are neutral, they don't have any action in the human body, right? Well, placebo needs to be exactly equal of the interventional, the new drug. So it has to have the same appearance, the same taste, smell, texture, appearance. So everything needs to be equal to the interventional, to the new drug, right? But what if I'm testing, for example, two drugs and they have different routes of administration, for example, or they really look unlike each other, they are different. How can I create a placebo but I cannot alter the route or of administration or the appearance of these two drugs? Well, then I'll have to create a placebo for both of these drugs, and then my patient will take two drugs, one active and one placebo.
For example, A active, B placebo, and then the other group, A placebo, B active, right?
That can be burdensome for patients, mainly because they already are taking another drug or placebo, but they are taking two drugs. If the route or the time of administration of these two drugs differ very much between each other, that can cause non-compliant behavior as well, that could increase dropouts. So we have to be very careful when we are talking about double dummy designs. There are some disadvantages here that can interfere in our data, in our study results, okay? And then finally, non-pharmacological treatments. We are talking about surgeries, we are talking about devices, we are talking about exams, procedures. How can we do a placebo of a surgery? Well, we can do a sham surgery, but that is also difficult. That is also susceptible to unblinding. Same thing for devices.
That is pretty difficult when we are talking about mental disorders. Once the interaction between a doctor and a patient has already shown to be positive, to have positive effects, so that is pretty difficult to access.
And a sham exam, for example, we can blind, physically and literally blind patients, and then take them to a room and then to do or not the exam. So there are several challenges here we have to pay attention. I'm not going to comment on all of them, otherwise this video would have, I don't know, more than 20 minutes. But that's it, guys. I just mentioned the overall of blinding, and I hope you enjoyed the video.